Good evening, everybody. My name is Dr. Nafi Aliasi. I'm a pediatric gastroenterology fellow here in Sheikh Khalifa Medical City in Abu Dhabi. First of all, my apologies for not being able to present live because of technical issues. So this will be a recorded video about my presentation about neonatal cholestasis. This is a very important topic. Can be seen as, you can see it as general pediatricians, as family physicians, and you will encounter several cases of those. So I will go through the presentation today. I will talk about the bilirubin physiology, how it forms and how it gets, the body gets rid of it. What are the causes of neonatal cholestasis? I will go briefly on how to differentiate between physiological and pathological jaundice, and I will focus more on the cholestasis, mainly the direct element of the hyperbilirubinemia. I will go with the management. How would you manage a case if you have a patient with jaundice coming in your clinic? How would you manage him or her? And the timely referral, when to refer and how to refer the patient, and the take-home message. Hopefully we'll finish in less than 25 minutes, so bear with me. So in general, the overview, the general definition of cholestasis is defined by the reduced bile formation or the flow. You know that the bile is formed in the liver, then secreted in the biliary tree. There are some defects that cause impaired bile flow. So this is leading to accumulation of the bile inside the biliary tree and the liver and eventually inside the body. We need to know that not all cases of cholestasis are due to liver disease. This is a very important point because some of them are due to other causes. We need to keep in mind that not all patients with jaundice are having a liver disease. Very important to know that early recognition and management can lead to favorable outcomes. Very important, especially in several cases, such as the metabolic cases or the biliary tree abnormalities that I will discuss later on. Going to this simple diagram of the bilirubin metabolism. So where does the bilirubin come from? Starting with the RBCs. As you know that the hemoglobin will be degraded to heme and globin. The globin will be degraded further to bilirubin. The bilirubin goes from the RBCs to the blood vessels, and the blood vessels will be bound to albumin, and this is the unconjugated bilirubin. So this is the indirect bilirubin. This is free flowing, can cross the blood-brain barrier. It will go directly through the enterohepatic circulation, through the portal vein, to the liver. Inside the hepatocytes, there will be the uptake. The conjugation process occurs inside the hepatocytes, inside the liver. There are several steps, several rate-limiting enzymes, several enzymes causing the conjugation of the bilirubin. After that, it will be secreted in the biliary tree, stored in the gallbladder. Some of it will go to the stool and the gut. It will be converted by the bacteria in the gut to urobilinogen, and some of it will be excreted in the stool. The other will be secreted as in the kidneys. So the conjugated bilirubin, to know that the conjugated bilirubin is taken from the liver, gets the conjugation through the gallbladder and the bile tree and gets excreted. So to make it simple, any problem in the liver, any issues with the liver or the biliary tree, you will have higher chances of having conjugated hyperbilirubinemia. Any chances of defects, any metabolic conjugated hyperbilirubinemia. Any chances of defects, any metabolic defects or genetic defects in the biliary tree or in the conjugation process, this will cause direct hyperbilirubinemia. We need to know that not all jaundice cases are pathological. The majority of them are physiological, basically. So you have to know that 50% of term babies, they might present with jaundice, especially in the first week of life. Nearly 70 or 80% of preterm babies, they might have jaundice. So not all of them are pathological. They might be physiological. And if they are pathological, they can be either direct or indirect. To know the physiological jaundice, these are some hints. Usually it appears after day 1 of life. It doesn't appear on the spot. Usually it gets the maximum intensity at 5 days for the term babies and 7 days for the preterm babies. It does not get prolonged for more than 14 days, except in cases of breast milk jaundice. And this is always indirect hyperbilirubinemia. So if the patient comes with direct hyperbilirubinemia, this is pathological by default. For the pathological jaundice, you have the unconjugated versus the conjugated. For the unconjugated, the direct bilirubin is less than 20% of the total bilirubin. And for unconjugated bilirubin, it's mainly hemolytic or non-hemolytic. So these are related to the RBC. These are prehepatic. This is not our talk today. I will focus more on the conjugated bilirubin. You will find out that the total bilirubin and the direct bilirubin is more than 20%, 20 and above. Some of them, they take a cutoff point of 25%. But if you have a patient coming with direct bilirubin of 20% and above, this is conjugated bilirubin, and this is always pathological. There are several causes, and I will speak about them in the later slides. So as I said, more than 20% of the serum bilirubin, if it's direct bilirubin, this is conjugated hyperbilirubinemia. And usually it lasts more than 2 weeks. Patient comes more than 2 weeks, you need to look for direct hyperbilirubinemia. Some patients, they might present from day 1 or day 2 with direct hyperbilirubinemia. So keep this in mind. This is always pathological, as I said. In cases of obstruction, biliary atresia, for example, they will present with pale stool. So a patient comes to your clinic with jaundice and pale stool, think of direct hyperbilirubinemia. You have to think of it, and you need to do total and direct bilirubin from the day 1. And I will put some pictures of the stool. You will know what I mean by pale stool. You have a diagram for that. So what are the effects of cholestasis or conjugated hyperbilirubinemia? You know that unconjugated hyperbilirubinemia, this is, it can cross the blood-brain barrier and it causes kernicterus. For the direct hyperbilirubinemia, it does not cross the blood-brain barrier, but it affects the biliary tree and it affects the hepatocytes on long term. They might cause hepatic injury, they might cause fibrosis and cirrhosis. And keep in mind the fat absorption, the fat absorption will be impaired, and even the fat-soluble vitamins will be malabsorbed. So we need to keep this in our mind. I'll talk later about the treatment, which is one of them is fat-soluble vitamins. So remember this: a patient has cholestasis, he will be having impaired vitamin. He will be having impaired vitamin absorption, especially the fat-soluble vitamins, vitamin A, D, E, and K. This is a very important slide. What are the causes of neonatal cholestasis? If you open the books, you will find probably more than 50 causes of neonatal cholestasis. So many of them are very rare. If I want to put them in pieces, we have mainly extrahepatic, intrahepatic, infectious causes, metabolic causes, genetic causes, endocrine, or miscellaneous causes. I just put here the most common ones that you might encounter in your clinic. So keep in your mind that for the extrahepatic, you might have biliary atresia, and this is very common. Choledochal cyst, although rare, but we see it. Bile duct stricture, spontaneous perforation of bile duct. In these patients, they will present, these patients will present basically with ascites and jaundice. Patients with neoplasm causing stricture, so causing any pressure on the biliary tree. Stones, although very rare in neonatal period, but you might encounter a patient with gallstones presenting with cholestasis. For the intrahepatic causes, you have the PFIC or progressive familiar intrahepatic cholestasis. I will talk about it later. You have a common syndrome called Alagille syndrome. We see it very often. Caroli disease or syndrome. You have ARC syndrome, which is arthrogryposis, renal disease, and cholestasis. This is a very rare entity. You might have idiopathic neonatal hepatitis. There are several causes, and with the presence of cholestatic panel and the genetic testing, we are starting to identify those idiopathic ones. Infectious causes, these are common. You might encounter a patient with cholestasis having sepsis. Sepsis is the cause of cholestasis in this patient. UTI, especially E. coli UTI, might present with cholestasis. Torch infection, toxoplasma, rubella, CMV, HSV. These patients might present with cholestasis, hepatosplenomegaly, and typical neurological features. HIV and listeriosis, not very common, but you might encounter patients with infectious causes. Metabolic, we need to keep an eye on metabolic causes, especially tyrosinemia, galactosemia, bile acid synthesis disorders, alpha-1 antitrypsin deficiency. For example, galactosemia is a common thing here in the UAE. Alpha-1 antitrypsin deficiency is very common in the European region, in Western region specifically. Here it's very, very, very rare. I mean, in Europe it's around 15%. Here I haven't seen any case in the last couple of years. For the genetic causes, you have several diseases. Trisomy 18, you have Down syndrome, they might present with cholestasis, although not very common. Dubin-Johnson syndrome and Rotor syndrome also, these are some of the cases which might present with cholestasis, and the treatment is just like monitoring and you don't do anything for, especially Dubin-Johnson. Hypothyroidism, congenital hypothyroidism might present with cholestasis. They might have typical facial features, the flat face and large tongues, and usually for hypothyroidism, you might detect it by neonatal newborn screening, which is done here in the UAE. Panhypopituitarism, they might present with hypoglycemia, cholestatic jaundice, and they might have neonatal, even seizures. I've seen a case last month, basically, with patient came with neonatal cholestasis, and the cortisol level revealed the diagnosis later on. We have cystic fibrosis. It might present with cholestasis, but not in the neonatal disease, usually later on in the ages. Medications such as some antibiotics, ceftriaxone, for example, it might cause biliary sludge leading to neonatal cholestasis. Antifungals. Patients might present with cholestasis due to antifungals, especially IV antifungals. Total parenteral nutrition. This is a common thing to be seen, especially in the neonatal period. So we need to keep an eye on these differential diagnoses. And from this differential diagnosis, you will start looking for the cause. If you have a patient coming to your clinic with jaundice, let's say jaundice, pale stool, the most important thing in the management is history. In order to think of the differential diagnosis, you need to take history, and after that history, you need to dig deeper in the history again. And again, you need to take history. Keep in mind that history will lead eventually to the differential diagnosis, and it will limit your differential diagnosis. Thus, you will avoid taking extra labs. Keep in mind that we need to take lots of labs if we don't know the differential diagnosis. If your differential is not narrow, you will spend a lot of time looking for the diagnosis. In history, you'll ask if the patient is term versus preterm. Preterm babies, think of sepsis, think of TPN-associated cholestasis. Prematurity itself is a risk factor for cholestasis. What is the birth weight and what is the current weight? If the patient is thriving well and having jaundice, think of biliary atresia, because biliary atresia patients usually are term babies thriving well, but they are jaundice and deceivingly, they look well. What is the onset and the progression of the jaundice? Did it start on day one, or did it start gradually after the second week? Stool color. Stool color is very important. And don't ask what is the stool color on. Show them a picture of the stool. Because sometimes you ask them, what's the stool color? And they will tell you, oh, the stool color is normal. But unfortunately, it is either number 1 or 2 or 3. The first 3 samples are the pale stool. These are the ones that are very worrisome for us. Number 4, 5, 6, and 7, these are the normal ones. So I suggest in your clinic, if you keep a picture of this stool, this is very important. What is the maternal serology? If she has one of the torch infections, this will lead you to the diagnosis directly. Did she have any medications, such as amphetamines or drugs? This might cause cholestasis. Did the mother have jaundice during pregnancy? These may give you a hint towards some metabolic diseases or progressive familial intrahepatic cholestasis. What is the family history? Is there family history of liver disease, transplant, liver transplant, any metabolic disease, renal disease, lung, or congenital heart disease? These family history sometimes might lead you to reach the diagnosis without doing further investigation. Did the patient take any medication such as antibiotics? Did the patient require prolonged TPN? These are very important hints toward the diagnosis. Physical exam, very important to plot the weight. Is the baby failing to thrive or gaining weight? Are there any dysmorphic features? Having dysmorphic features will lead to several entities. Eye exam, of course, you will get the ophthalmologist to help you. I will go further later on. Because if there is posterior embrotoxin with jaundice, you will think of Alagille syndrome. If there are cataracts, you will think of galactosemia. You need to put your stethoscope and listen to the heart. If you hear any murmur with stenosis, especially peripheral pulmonary stenosis, you will think of Alagille syndrome as well. Abdominal exam, if you feel splenomegaly, think of portal hypertension. Definitely there will be a liver disease in this situation or prehepatic disease. Genitalia, if there is micropenis in a male, think of hypopituitarism. Any purpuric rash or cafe au lait spots, any rashes are sometimes giving you good hints. If you see purpuric rash, you will think of congenital CMV or rubella. If you see cafe au lait spots, think of McCune-Albright syndrome. Any hypotonia or any hyperreflexia, this might also give you a hint towards any metabolic diseases. I'm sure you are waiting for this slide. This is one of the most important slides I'm presenting to you today. So what are the investigations? What do you need to do if the patient comes to your clinic and he has jaundice? He has a specifically direct hyperbiliary. You have three levels of investigations, labs. Tier 1, in your clinic. The patient comes to your clinic, please do the following test. You need to do CBC, liver enzymes. Gamma GT is a very important thing because it can exclude several diseases. Total and direct bilirubin, glucose, thyroid function, iron profile, ferritin, urine analysis and culture, cortisol level. Random cortisol is fine. Urine for CMV, alpha-1 antitrypsin, torch screen if you can get it, the maternal torch screen, and try to obtain the newborn screen. This will be at the level of the family physician, the level of primary healthcare physician, or the GP, or even the pediatrician. If you see direct hyperbilirubinemia with element of increased liver enzymes, please pick up the phone and call the gastroenterologist. I prefer that you refer the patient on an urgent basis because timely manner of diagnosis is very important. And once we receive the patient, we will consult our friends in the metabolic disease. We will do all the set of labs, organic acids, amino acids, plasma and urine, ammonia, lactate, sweat chloride, lysosomal acid lipase, this is a blood spot test, galactose 1-phosphate for galactosemia, bile acids, both urine and plasma, HIDA-scan, we will start preparing for HIDA-scan to rule out biliary atresia, X-ray for the spine, looking for Alagille syndrome, especially the patients having butterfly vertebra. We will refer him to the cardiologist to do an echo and the ophthalmologist, and we will consider doing liver biopsy. The third level of the testing is the cholestasis panel and the targeted molecular testing. Usually this is the step 3. If we cannot reach the final diagnosis in tier 1 or tier 2, usually we'll go to the tier 3. And for the cholestasis panel, you have 23 genes so far detected. And usually this test takes about 4 to 6 weeks. Now the cost is around 1,000. I think in the future, the cost will go even down and it will be more available and easier to test. I'm sure there are some limitations, especially with the insurance, but over the years, it's becoming easier and more readily available to test. And I'm sure in the future, we will not be doing all those expensive tests. We will go directly to the cholestasis panel if we can get the result within a week or less. I will go to several examples of cholestasis. And these are the ones are related with GI disorders, the ones that you need to detect in your clinic or suspect in your clinic. One of them is biliary atresia. This is one of the common causes, or actually the commonest cause of liver transplant in pediatric children. This is more common in term infants, and the infants will be deceivingly normal looking, except for jaundice. They will be healthy, they will be feeding well, they will not be sick looking in your clinic, but they will have jaundice and pale color stool. They will have, as I said, direct hyperbole. They will have high gamma GT, usually in the hundreds. If you do ultrasound fasting, you will not see the gallbladder, it will be contracted. The definitive diagnosis, you'll do the HIDA scan plus the intraoperative cholangiogram. The treatment is very important. You need to do the Kasai procedure. This is a surgical procedure before the age of 8 weeks. So keep in mind, if you have a patient suspected for biliary atresia, do not refer him to the clinic. Pick up the phone, call the gastroenterologist. I think the doctor will see him same day or the next day. These ones are very important to be diagnosed before the age of 8 weeks. If you diagnose them after the age of 8 weeks, the damage is done for the liver and it will be too late. The patient will start having cirrhosis and liver failure, and you need to do quickly a liver transplant. I mean, you have to start arranging for transplant. And unfortunately, we get those cases sometimes. We get a referral, patient comes like 2 weeks later or 1 week later to the clinic, and we discover that the patient's having biliary atresia based on the ultrasound and the HIDA scan, and sometimes it's a bit late. So diagnosis is very important in this entity, which is biliary atresia. You need to diagnose them early. The other entity is called progressive familial intrahepatic cholestasis. This is an autosomal recessive disorder. They will have disruption of the bile formation. They will present with jaundice, pruritus, progression of liver failure. We have several types. Keep in mind that type 1 and type 2, they will have normal or low gamma GT. They will have direct hyperbole, but normal or low gamma GT. Type 3 will have high gamma GT. So if you see a patient with direct hyperbilirubinemia and normal or low gamma GT, think of PFIC. Although this is not very common in Europe, but this is common in our neighbor countries. In Oman, this is the most common cause. And in Saudi Arabia, nearly 25% of cholestasis patients are having PFIC. So we need to keep this in our mind. Our we have like more than 200 nationalities in the country, but the local nationalities, we need to focus on PFIC. And we have several patients with progressive familial intrahepatic cholestasis. Usually the outcome for them is favorable if you treat them early. Some of them, they will require liver transplant later on their childhood. Alagille syndrome. This is one of the common causes of direct hyperbole. This is an autosomal dominant disease. It can be sporadic. The patients, they will have typical dysmorphic features. You'll notice the triangular face, prominent forehead. They will have direct hyperbole. They will be jaundiced. Usually, you will not detect them in the neonatal period. You will detect them later on childhood. They will have peripheral pulmonary stenosis or sometimes VSD or other cardiovascular anomalies. They will have skeletal anomalies such as butterfly vertebra. That's why I said we need to do an X-ray for the spine. Sometimes they will present also with posterior embrotoxin, so an ophthalmo exam is very important. And the treatment for them is liver transplant later in their childhood or sometimes in adulthood. TPN cholestasis, this is a very important entity, especially if you are working the NICU. I'm sure you've seen this already. Nearly 40 to 60% of the neonates who are on prolonged TPN course, they will have some sort of TPN cholestasis. And you have a wide range of findings. They might have only a sludge, gallbladder sludge, which can be treated only with fluids. They might present even with severe liver disease, liver failure, and cirrhosis. What is the pathogenesis? There are several causes. One of them is the prolonged use of TPN, more than 2 weeks, the lack of enteral feedings. If the patient is kept NPO for a long period and kept on TPN, there will be a risk of TPN cholestasis. Length of bowel, short bowel syndrome, patients who present with necrotizing enterocolitis and requiring resection of the bowel, they will have short bowel. They will be at higher risk of developing TPN cholestasis. And the components of the TPN, keep in mind, the components itself, the excess glucose, amino acids, and the fat emulsions, they might be one of the factors causing the cholestasis. What is the management of TPN cholestasis? This is a very important thing. First of all, try to feed the baby as much as tolerated. The more feed, the lower the risk of TPN cholestasis. Try to provide cyclical TPN as soon as possible. And keep in mind, it's better not to feed the baby 24 hours. Lower the rate of the TPN. Keep him feeding for 20 hours per day. Because, I mean, normally human being will not be feeding 24/7. So feed him for lesser time. Try to minimize the lipids as well. The lipids, if you can make it for 12 hours a day, or sometimes we keep it alternate days, sometimes twice a week. This will help in preventing TPN cholestasis. And treat the small bowel bacterial overgrowth. Sometimes we start the patients on cyclic antibiotics to treat the bacterial overgrowth. This might help in reducing the TPN cholestasis. Unfortunately, if they don't get improved, they will later on develop liver failure, cirrhosis, and some of them, they will require liver transplant in the long run. So keep in mind, TPN cholestasis, if it happens, this is devastating for the patient and the family. So for the management of the neonatal cholestasis, these are the general factors in the management. You have the specific ones, and these are tailored for the patient and their disease. Every disease has a specific treatment, but in general, first of all, you have to optimize caloric intake for the patient. Usually, the patients will require around 130% of their caloric intake. So be liberal in their caloric intake. I'm talking about a neonate with cholestasis, not the ones with TPN cholestasis. The supplementation of the fat, preferable is through medium chain triglyceride-based formula. You have several formulas. I prefer 30 to 50% MCT because of the absorption will be better in those cases. Very important to provide the patients with fat-soluble vitamins. You have to be liberal with the doses of vitamin A, D, E, and K. Give them higher doses. Don't go with the lower doses because the patients will require those vitamins. If the patient is having pruritus, you can give them also deoxycholic acid. The dose is usually 30 milligram per kg per day divided into 2 doses. Cholestyramine will help in itchiness. If they don't improve, you can add even rifampicin. So the take-home message: prolonged jaundice warrants further investigations. If the patient comes with long jaundice more than 2 weeks, please do the investigations that I explained, especially tier 1 investigations. Not all cholestatic jaundice are liver-related. Many of them are medication-related. Some of them are metabolic causes. So we need to dig for other causes. Very important to recognize and manage those patients because the earlier management, the better the outcome. And that's it for our presentation. Thank you very much.
Thank you for playing the